6, we're going to be talking about preparing for the maintenance phase with your GLP-1 patients. And I will move to today's agenda. So today we're going to talk about important factors when weaning off of the GLPs. We'll talk a little bit about transitioning to other GLPs if that is appropriate for certain patients. We'll talk about really assessing the clinical overview of a patient when they're getting ready to transition. A second, I'm just going to allow people to get in here. We'll discuss what may keep patients stuck in the maintenance phase. We're going to talk about medications that contribute to weight loss resistance and nutrient depletions. And we'll discuss environmental substances that contribute to weight loss resistance. So the majority of this presentation, we're really going to be focusing on when the patient is off the GLPs, but I did want to add this slide because I think it's really important to really understand why a patient wants to wean off of the medication, because it could be for so many different reasons. Maybe they're having side effects, maybe they have achieved or reached a plateau, they're no longer losing. Maybe they, due to budget reasons, they want to go off of it. So really understanding that piece. And, there might be an opportunity to talk about a different option if they still have a ways to go to, achieve their optimal health. So, when you are considering, recommending a switch to a different GLP, you want to kind of, just know, obviously, we've talked a lot about like the differences and things like that. And I just wanted to point out how we look at transitioning patients from one to another. And when we're starting patients on GLP-1 medications, we are typically starting with semaglutide. There is no right or wrong reason. Obviously, right now we just have semaglutide and tirzepatide. I mean, there is the oral semaglutide as well, but we're not using that at this time. We're just sticking to like the semaglutide, the tirzepatide, and then we also offer retatrutide. So not to confuse things, some people might be on tirzepatide and go to semaglutide. They might be on semaglutide, go to tirzepatide. So you can really go back and forth. And I just think it's worth pointing that out because I feel that a lot of patients, when they've tried, a specific GLP, say like semaglutide, they had a bad experience, and then they've kind of forgotten about it and think that it will never work for them. But just kind of, when looking at the whole picture and looking at the state of health for a particular patient, as they're on these, they may be getting into a healthier state, so their body might respond in a much different way when going to a different product. So just know that if it makes sense to keep someone on a GLP because they were having really good results, always keep in mind that you can switch back and forth. We are typically switching patients off of semaglutide to tirzepatide if there are significant side effects. The studies on tirzepatide and retatrutide show that these particular GLPs have less side effects, and we definitely see that in our patients as well. So again, everyone is different. I wanted to just highlight that because if it warrants further conversation at the end, we can definitely dig into that. But the focus of this presentation is really talking about what happens after they're done with taking the GLPs. So it is really, really important to get a clinical overview of the patient. So just like at the beginning when you are, doing your initial assessment, kind of getting an idea of where the patient is at, you want to do the exact same thing at the end of their program. So that would entail, reviewing their medical intake form, looking at, looking at their symptoms again, assessing any labs if those are available to you, always looking at gut health, looking at lifestyle habits that could be contributing to certain, toxic exposure that we're going to talk a lot about. You want to assess their current medications, you want to look at their supplements, and we can't forget about the sleep and the stress, because that if a patient is in this state of turmoil with, they're constantly stressed, which is causing sleep issues, I mean, that's going to kind of keep them in that stuck state. So these are kind of like the key components, and we're going to, dive deeper into all of these sections. So you want to review their medical status. Again, maybe going back to the intake form. What is their current diagnosis? Because that's gonna give you insight into their level of metabolic dysfunction that they still could be, dealing with. And I say it all the time because patients will say, all right, they start the program. What happens afterwards? Am I going to regain the weight? And I always answer the question by saying it depends on your health when you stop the medication. It depends on your metabolic health. And so the diagnosis is really important. Are they dealing with autoimmune conditions, any type of inflammatory bowel conditions? What are the lifestyle diseases that are still going on? Are they experiencing reflux? Are they being treated for high cholesterol, blood pressure, sleep issues, that type of thing? Do they have asthma, diabetes, etc.? So that's going to give you really good insight into their metabolic health when they decide they want to stop the medication. And again, if you have access to labs, reviewing that can really provide some great insight into like maybe some areas that you can support them as they go into the maintenance phase. Symptoms are significant. I know Erica dug into this at our monthly webinar. I don't know if any of you were able to join that, but assessing symptoms is crucial. Assessing symptoms at the beginning and then obviously at the end, and during the program as well, and then at the end is really important. So we have provided, our symptom assessment that you're able to use and modify, to fit your environment and that type of thing. But we're always looking at certain segments like, physical presentation, hair, nails, tongue, skin. We're not really doing like the physical assessment per se, meaning like, looking at their nails, looking at their tongue, but we're looking at the symptom assessment. So if they're complaining of their nails are brittle, they're losing their hair, they have, skin rashes, things like that. That's going to give us insight into potential vitamin deficiencies. Could there be something going on with their thyroid? Have they had their thyroid checked lately? Rashes are a huge indication that they could be experiencing food sensitivities. And then just, protein deficiency. Are they getting enough protein in their diet? Physical symptoms such as, eyes are, they have they're, bloodshot eyes, they're have ringing in the ears, they're congested, they're always clearing their throat, that type of thing. That's going to indicate to me, some type of environmental exposure. So, this is an indication of like histamine allergies. Whenever I see a lot of like the upper respiratory symptoms on patients' assessments, I'm always asking questions about mold. Have you been exposed to mold? It- it- have you had water leaks in your house? Kind of just digging deeper to see if there might be something that you can uncover with, why are they having these types of symptoms? Neurological, so, patients after the program, if they're still dealing with a lot of anxiety, brain fog, dizziness, some are reporting balance issues. It could be a neurotransmitter imbalance, blood sugar dysregulation, inflammation. Again, it could be environmental, the brain anxiety, things like that. That could be like heavy metals. We do ask on our intake form if patients have the silver amalgams. I never can say that word, but the old school fillers that they used for cavities. I've had a handful of patients who are really dealing with some significant health issues because of the mercury and the other heavy metals that they're being exposed to because it's in their mouth. So, kind of just again, just digging a little bit deeper into like the whole picture. Changes in their energy, their sleep, obviously their weight, and the frequency of illness. Do they get chronic infections? That's usually an indication of, hormones, nutrient deficiencies, again, environmental exposures. A big one, sickness frequency, I'm always looking at the gut. So that the gut could fall under that category as well. And then GI symptoms, if they're still experiencing constipation, diarrhea, stomach pain, reflux, we're looking deeper into the gut. We understand that not everybody's going to be working with like gut testing, but these are some of the imbalances that we see when we're digging deeper. Many patients are dealing with like H. pylori, candida overgrowth, hyperchlorhydria. So, acid levels in their stomach is a problem, leaky gut. And we also find when we're doing, more deeper look into their gut, we're looking at the balance of the keystone species. And oftentimes because of the overuse of like antibiotics and things like that, antibiotics have literally extinct some of the really healthy keystone species. So again, just kind of an overview of different ways that you can look at a patient, the overall picture when they're transitioning into the maintenance phase. And then, of course, there's the body comp metrics is really, really, really important. I know we talked about this several times in our presentations, but it's not just about the weight. We really do have to know how much body fat they lost. Did they lose some muscle? How much total skeletal muscle do they have? Visceral fat is huge, as you all know. Is there some way to measure level of water retention or inflammation? And again, reviewing any labs that you might have access to again, always trying to get that total picture of the patient's health when moving them forward. Medications are a problem. Oh my gosh, we're going to talk more. We're going to dig into specific ones that are really contributing to weight loss resistance. But I am always, after a patient completes a program, kind of, going back to the basics, reviewing their medications, do they need to still be on it? Do they need an adjustment in dose because they've lost 30 pounds, 30 or 50 pounds, right? So these are conversations that you can have with the patients so that they can go back to their doctor and have these conversations. Are they on medications that are known to cause weight issues? And is there an alternative? Really looking deeper into like certain medications, and we'll talk a little bit about like some alternatives, but these are things that can be really important, especially if they're still on kind of like a slew of different meds. So these are the common medications that do have an effect on weight. They also are very much, it contributes also to nutrient depletion. And we're eventually going to provide like a handout that gives like common meds and nutrient depletions that are very common, but we'll talk a little bit about them today. But always kind of keep that in mind that when patients are on medications, there's usually you usually need to go deeper into looking at what nutrients do you need to replace. So these are the common ones: antidepressants, hormones, antihistamines, beta blockers, sleep aids, steroids, diabetic medications, mood stabilizers, antiepileptics, and antipsychotics. So antidepressants, I think we're all familiar with the SSRIs: Prozac, Zoloft, Lexapro, Celexa, and Paxil. I've seen them all have an effect. I know Paxil is kind of known to we used to call it back in the day like pack it on with Paxil, but the other ones can contribute as well. The SNRIs like Cymbalta and Effexor can have an effect, and some of the TCAs. I don't really see TCAs as much, but they're still being prescribed. So what antidepressants, how they contribute to weight loss resistance or weight gain, they interact with acetylcholine and histamine receptors. So when blocked, when these histamine receptors are blocked, this can increase the patient's appetite. So they're going to eat more. They interfere with serotonin levels, and serotonin regulates mood and appetite. So if it's too low, they may have more cravings for sugar and carb foods. They may trigger changes in metabolism that cause the body to use calories less efficiently. And common deficiencies while on antidepressants are going to be B12, folate, magnesium, zinc, omega-3s, and vitamin D. So you're going to see a common theme with these medications. So making sure that you're assessing the supplements. And again, we are going to talk about this, but assessing supplements at the end of the patient's journey. Synthetic hormones, I think we all know that these can absolutely contribute to weight loss. I mean, weight loss resistance for sure, but I have seen patients lose or gain a significant amount of weight when starting these. So they can cause fluid retention, they can increase your appetite, and they can alter your fat metabolism. They also can disrupt other hormones in the body. Common deficiencies: vitamin B6, B12, and folate are essential for people who are on these synthetic hormones. This is not bioidentical. We're talking about the synthetic ones. Antihistamine, people are taking these all the time as well. And, the Zyrtec, Allegra, Benadryl, these affect, again, the histamine affects the control centers in the brain. When you block this, it really can drive hunger. So it's really the eating more that is potentially going to cause, the weight loss resistance. Beta blockers have a lot of different ways of causing some issues with patients. They really do a number of things. So they can reduce resting energy expenditure. They can prevent the pancreas from producing more insulin. So obviously, we don't want that. They can reduce the thermic effect of food, reduce exercise tolerance. Beta blockers can actually damage the mitochondria, just like the statins. They can increase fatigue. We've noticed that patients have this like exercise intolerance when they start these medications. So, being mindful of that. It could be the medication and not just, like the food and other things that they may be doing. They've been shown to inhibit lipolysis, and common related deficiencies to beta blockers are potassium, iron, melatonin, and CoQ10. We're not going to be talking about statins because statins technically they don't fall under like the category of contributing to weight gain, but they have a whole host of other issues that contribute to metabolic dysfunction. And CoQ10 is going to be really, really important for again for the statins and the beta blockers. Sleep aids, I see it all the time. When people are relying on sleep aids to fall asleep, they have a hard time losing weight. And this has an effect on their appetite. I mean, we all have worked and seen people that are on these sleep aids. It just affects their entire day, their quality of life. And but it also can affect their metabolism. There are probably a ton of studies. I know there was a recent study on zolpidem showing that it increased the risk of type 2 diabetes. So again, bringing awareness to the fact that these medications, these lifestyle medications that are being prescribed so often are really causing, significant issues when patients are trying to continue their weight loss journey. Glucocorticoid corti- corticoid steroids. So prednisone, hydrocortisone, steroids alter the body's electrolyte balance and metabolism. They cause changes in fat deposition and they increase appetite. And it can happen pretty quickly. They can increase blood sugars. They can cause the liver to produce more glucose. They can increase your chances of fatty liver. And common related deficiencies to these steroids are calcium, vitamin D, and electrolytes. Diabetic medications, I think we all understand that they can increase weight because they're kind of like considered, well, especially insulin, like the fat storing hormone. So they cause the body to retain more calories. They can cause episodes of hypoglycemia, which obviously in turn can cause more overeating. And we almost always see B12 deficiencies tied to these types of medications. So that's why you'll hear a lot of patients complaining of fatigue. And, sometimes you might think, oh, well, maybe there's having issues with managing their blood sugars, or maybe they're just not eating enough, but really it could be that they're so depleted of vitamin B12. Antipsychotics increases the incidence of metabolic syndrome due to a number of things. So, specifically to the interactions with receptors involving serotonin, histamine, dopamine, and the adrenergic receptors. So this definitely is one that we're kind of looking at when our patients are having issues. Common related deficiencies are calcium and melatonin. So you see melatonin is like a common deficiency in these types of medications. And, our patients already are having a hard time sleeping. So maybe it's an opportunity to kind of look if that could be a cause as well. Medications, we know kind of what they do in isolation, but we don't know what they're doing together. And so this is another problem. And it's this type of thing that does kind of drive me bonkers because I mean just think about what that could mean and what could be going on in the body. Set aside just one medication, but now you're adding, I mean, I have some people that are on 7 to 10 medications. So kind of reassessing, understanding the dynamic of what could be going on, and is there an opportunity to get the body in a healthier state so we can start to help patients start the weaning process. These are just some possible alternative options, and this is specific, obviously, to the ones that could be contributing to weight loss resistance for some of your patients. Antidepressants, bupropion, 5-HTP, focusing on the gut. If people have a lot of brain anxiety, depression, we are always looking at the gut first because the gut and the brain are one unit. For synthetic hormones, you can look into bioidentical. For antihistamines, we have used bromelain, quercetin, a few times, but there's definitely more. Beta blockers, you can look to recommend, switching to ACE inhibitors. There's a lot you can do for sleep. It's probably one of the first things that I don't, I'm usually addressing sleep meds pretty early on with patients because even while they're on a GLP, that is also could be holding them back. So looking into like, are they a fit for melatonin, CBD, GABA, or I have melatonin on there twice. Steroids, there's a compounded low dose naltrexone that some people have found to be really helpful for inflammation in the body. And then obviously for diabetic agents, we could do the GLP-1. So in summary, lifestyle meds, I mean, and again, I know we all understand this, but I think it's worth reiterating that these are lifestyle medications, right? So let's fix the lifestyle, let's fix the body, let's get the body into the healthier state so we don't have to rely, so patients don't have to rely on the meds because they do alter normal physiology. I want to say that, and I do say often with some nuances, is that GLP-1s mimic normal physiology. But there's many that the ones that I just kind of went through, they definitely alter what would normally happen, in a body in normal situation. We forget to look at what is in the products. And so digging deeper into, if somebody's having persistent gut issues, they're eating clean, they seem to be doing everything right, but maybe they're taking a medication that is full of additives, dyes, fillers, etc. These lifestyle meds are designed to suppress the symptom while the illness remains or actually worsens. There's no known effects of combining multiple meds. Most medications are not taken as indicated on the package insert. So asking patients not only what medications are they on, but how long have they been on the medication? Because I just feel like patients are being prescribed certain medications and then it's never discussed again. It is done, they're on it for life. When some medications are looking at just looking at the package insert, they're supposed to be on it for 2 to 4 weeks and they're on it for 5 to 10 years or more. So that's a very important piece. Most of these lifestyle meds cause nutrient depletions. So there is a site called MyTaven. I have not used it. I use a different resource for it, but when I was doing some other research, I actually went to the site and it looked like you can put in the medication and it's going to tell you what nutrients or supplements to replace because of the depletion from the medication. 80% of all chronic diseases that exist today are preventable, which is kind of crazy because we just assume, and it's just, kind of a narrative that, over time we just get sick and that is the unfortunate thing. And, oh, it could be, is it genetic? My family, everybody, 50% have autoimmune or diabetes when really we need to look at this differently because this is all for the most part, majority of diseases we can prevent. All right, I'm going to talk about obesogens. Hopefully you've all heard this term. Obesogens are chemical compounds that affect normal development and the function of lipid metabolism and the endocrine system. So they are known to alter fat storage, they will alter set points, and they will disrupt the energy balance in our body. They modify appetite regulation, they put a strain and burden on the liver, and they're essentially like poisoning our body. So there are so many studies. I pulled a couple resources if you're looking, if you want to look up some of these, but I have a whole platform where I'm constantly pulling research and it was easy. I mean, I easily pulled 4 to 5 that I thought looked really interesting. So again, the research is out there. I'm not, making any of this up. But obesogens are everywhere. They are in our food and water, they're in our toys, in our cookware, our cleaning supplies, and our personal care products. So what obesogens do in the body is they increase the number of fat cells. So it's kind of like there's the inflammatory response, and then that inflammatory response kind of starts this whole cascade, and it not only increases the number of fat cells, but it increases the size of the fat cell, the capacity of it to store more. It shifts the energy balance to more energy storing. It alters our basal metabolic rate. They alter our basal metabolic rate. They destroy our gut microbiome and modifies our hormonal control, appetite, and satiety centers in the brain. So this is the standard American diet, but in addition, I mean, we're exposed to these things everywhere in our environment. And this is an opportunity to just, again, be a little more aware of how much either you or your patients are taking in every single day. Obesogens are in our food. So growth hormones that are added to meat, eggs, and cheese. So these are food, they, are injected with these hormones to increase their mass because they want to make more, obviously, to make more money. Antibiotics are used all the time. So there's antibiotics in our food. These animals are not treated the best and they're treating the animal infection. So that obviously is in our source and we consume that. High fructose corn syrup, we're all pretty much aware of the issues that surround that. And then the additives. So there's additives in everything. I think we've talked enough about like the regulation of additives and obesogens and things like that. And it's not regulated. The FDA plays a very, very small part in regulating things that go in our food. That's why there's the generally regarded as safe or GRAS. That is the term that really just allows all manufacturers to kind of put whatever they want in the food. So we have to be a little bit more diligent when helping our patients determine what's going to be, the healthy next step as they transition into healthy eating. Tap water is terrible. Heavy metals are leaching from the pipes are getting into our water. The modern plumbing is now made of PVC, which is a major obesogen. Fluoride is added to our water. If you're interested, you can read on fluoride because there is a lot of research looking into how it can contribute to a lot of diseases. Fluoride is a goitrogen, so it can lower iodine in the thyroid, which obviously can lead to hypothyroidism. It's obviously a major obesogen. We're consuming it every day. It's in our toothpaste. It's recommended for treatment by our doctor or by our dentist. So here's an opportunity to maybe look at, is this a conversation that should be had with certain patients? Utah and Florida just recently banned the addition of fluoride to the public water systems, and 5 other states have started the process. And this is pretty new. I've been hearing a lot about fluoride for the past 5 years. So we're starting to see that there are definitely some changes starting to happen to protect the public. So where are toxins stored? Because, our body can handle a certain amount of toxic load, but because of, the diseases of modernity, because of the standard American diet and all of the 80,000 chemicals that are allowed in our environment, our body's overburdened. And and when we can't get rid of them, our body has to find a way to store them. So most are lipophilic, meaning they accumulate in the adipose tissue. They can accumulate anywhere. I mean, they can go, some will pass the blood-brain barrier, but they tend to accumulate in like the visceral fat area. So this contributes to that whole cascade of weight loss resistance because the visceral area is already inflammatory, right? These are inflammatory fat cells, and now you're starting to add more of the toxins into that area. Those fat cells are completely destroyed, and that's the body is not able to access that for energy. When you go on quick weight loss, I mean, we do a lot of like quick weight loss programs at Weight Loss MD, and we have to plan for that mobilization of toxins. And I mean, most people are familiar with the keto flu. So if you're on a keto diet and your body's in like that fat burning, fat mobilization mode, those toxins will come into circulation. That's why people will complain, at the beginning of like the keto, they have the keto flu. And when those toxins come out in circulation, they actually can be reabsorbed right back in. So knowing and understanding how to support certain symptoms during weight loss is really important. And I apologize for this slide, but I had a ton of slides, and we kind of like decided to just put it all in one because these are just areas where we're getting a lot of obesogens. And you can see from, our shampoos and our conditioners to our tap water, the air fresheners are just absolutely awful. Um, what other one? Cleaning supplies, our toothpaste. You probably heard me say it in another presentation, but if you read like a Colgate or a Crest, if you're still using that toothpaste, that needs to be replaced. It literally says if you swallow, you need to contact poison control immediately on a toothpaste bottle. So just sit with that for a little bit. It's totally nuts. So this is an opportunity, when working with somebody, if there's weight loss resistance, could they be just getting too much of the toxic load? Signs of toxicity, again, weight loss, weight gain, weight loss resistance, constipation, fatigue, skin problems, headaches or migraines, mood swings, bad breath, muscle pain, temperature deviations, overheating, sweating, insomnia. So these are some of the typical things that people are experiencing. So it might just be the toxic burden. Okay, so now we kind of bring it all together. Looking at the medical intake form, looking at possible medications, looking at, exposure, environment, is there, something else holding them back? And so this kind of, summarizes all of that. When transitioning off, there's many different things that we're looking at because again, it kind of is assessing where the patient is at. Are they at their goal weight? Have they reached their goal weight that everything is looking good? They don't have any more symptoms, like they feel great. So you really just have to kind of look at where they are at when they are done with the program. If they are somebody that they want to stop the GLPs, they're not doing well with it, they're done, they can't afford it anymore. We have programs called strategic weight loss, which we're going to talk more about in other sessions. But these are awesome because it's weight loss that completely resets someone's metabolic health. Some other options for maintenance would be like a low dose or a microdose maintenance option. So if somebody is ready to wean off, but they're not entirely ready to go off of it in, cold turkey, there are different protocols for just staying on the medication, on a very low dose. And then we'll talk about supplements that can support the mechanism of GLPs and we'll talk a little bit about customizing a meal plan. I know we've talked about the diet and nutrition a lot, so we're not going to go into a lot of detail, but just kind of hit some highlights there. I mentioned strategic weight loss. I just wanted to, again, give you a little bit more of an idea of what strategic weight loss means when we say it. When you lose weight quickly, you have to be prepared to deal with the toxic load. So our programs like support detoxification when a patient is losing weight quickly. We have to target the visceral fat. We have to be able to access the inflammatory fat stores, because just cutting calories and telling someone to reduce their calories will rarely, if ever, target visceral fat. The meal plan has to be very specific because we have to limit the blood sugar dysregulation when someone's really trying to maximize their metabolic health. Meal plan, obviously, we focus on anti-inflammatory foods. And the whole goal of strategic weight loss is to get the body to use its own fat stores for calories, because again, we all store, well over, 300,000 calories in our body. Probably not leaner people, but when you get up there in weight, you have a lot of calories stored that can be used. Assessing supplements, just like assessing medications at the end of someone's program. What are they taking? What is the quality? Just like the medications. Is it a Nature's Made from Walgreens that's full of stuff? There's an opportunity to just educate the patient. Get on a higher quality supplement regimen. We are constantly customizing supplements. We definitely have like our non-negotiables, like these are almost like essentials, which I'll talk about, but then it's really being able to identify and customize a protocol for patients. Again, there are the GLP-1 boosters that are available that we use some of them. We're going to be getting more into them in the next quarter, but that could definitely be an option as people, wean off the GLPs. Can they stop taking some? Maybe they've taken a certain product forever, and now it's time to maybe, take a rest on certain supplements. Educate patients on the dangers of retail supplements, purchasing through Amazon. There's enough information that we know now that everything on Amazon is not through the credible manufacturer, so you just have to be mindful of that. And then always kind of going back to the medications, if you know they're going to be staying on certain medications, then referring back to what those nutrients, what the potential depletions, and replacing those nutrients for them. These are essential supplementation. This is what we consider pretty essential. We probably put everyone on magnesium, vitamin D, K2, vitamin B12 or a B complex, some type of anti-inflammatory product, so whether that be fish oil, curcumin, resveratrol, probiotics and prebiotics, fiber, if they're not getting enough fiber in the diet, which most people are not, but you have to be very careful with fiber, which we talked about in the other presentations. A good multivitamin or multivitamin mineral is probably a good idea. I don't usually recommend that somebody take a multivitamin every day, but I think like 2 to 3 times a week would be sufficient. And then if somebody is dealing with a lot of gut issues, you'll want to use supplements that are like liposomal or liquid, sublingual, something along those lines, because it can, if there are a lot of gut issues, there's a really good chance that a lot of these supplements are not even being absorbed. So just some examples of supportive supplements. we feel like we're always supporting like the liver, and you want to make sure that you support phase 1 and phase 2 detoxification. These are just some examples. I did actually add names of companies of ones that we use pretty frequently, and we don't partner or, make anything off of recommending these. I just added it for simplification if anyone wanted to try any of them. But dual tax DPG by Numedica, bitters by Quicksilver, liver GI detox by Pure Encapsulations, um, blood sugar, insulin support, alpha lipoic acid is where we use that all the time. We use berberine and chromium as well. Yeah, we use all three of these. And then mitochondrial support, L-carnitine can be very helpful in really mobilizing those inflammatory fat cells, like getting those into the mitochondria. CoQ10, and there's a product called mitochondrial ATP that can be really helpful. Gut health support, usually everybody needs some sort of gut health support. It's just what is so essential in this day and age. So pre and probiotics, if we're usually using like hydrolyzed fiber powder, not patients typically, if we're using other types of fiber, if there's gut issues, they're going to have more gut issues with that. So that's why hydrolyzed can be really helpful. Digestive enzymes can be really helpful. Prebiotics, very, very important. We use Megapre, and then Megaspore for the probiotic. I use Proflora a lot from Biocidin Botanicals. I love that product. And then Pendulum, which I think most people have heard now. They hit the market pretty hard. They have a lot of great products that really focused on not only the gut, but like GLPs. So that can be an option. And then supportive products for sleep and stress. So anything that can support the cortisol balance in the body. We use L-theanine, liposomal GABA, and phosphatidylcholine for those conditions. And then the diet. So assessing a patient after a program, again, is looking at their metabolic health because the diet is going to be different. So if they are metabolically healthy, they will do better with carbohydrates. So you can incorporate healthy carbohydrates. If they still have a lot of metabolic dysfunction, they are being treated, for metabolic dysfunction, then it's probably a good idea to continue limiting the carbs for a while. Obviously, the diet must be clean. You can consider intermittent fasting as a way to really reset and keep the body in more of a fat burning mode. I'm always talking about snacking with patients because I feel like too many people are just like putting something in their mouth all day long. And every time you put something in your mouth, you're basically telling your body not to be taken out of like that fat burn mode, because now it's just going to go after the sugar or the carbs that is coming in. If you are calculating calories for patients or assessing calculating their calories, looking at their BMR, and setting calories that way, just be mindful that those calculations are not as accurate anymore because of the state of our metabolic health. And if you're not able to assess like the muscle mass and the body fat composition after a program, that's going to be a little tricky as well, because that's such a great way to really know the success of the program. Were they on it for 3 to 6 months, and did they maintain their muscle mass and lose all fat, or did they lose a lot of muscle and not as much fat? That's a whole different maintenance plan. Okay, so wrapping up here, we are going to provide you with our transition booklet that you can use with your patients. It just kind of gives them some guidance. I think we added some supplement recommendations in there. And then just some other things that you can think about for your maintenance support, because the main goal is how can you get your patients to stay accountable and remain connected to you. So we have different maintenance programs that we use, and usually they're more of like monthly visits. So inexpensive way to just touch base with you, on a monthly basis, or, you can extend that if that works better. Is there a way for patients to continue food logging? I mean, we have our own app, so they can continue to use our app and log their food and still be accountable to themselves after. Measuring body comp while they're in the maintenance phase is so important. So whether they have something at home where they can get on, the scale every month, or they can use it at their gym, maybe they do a body comp every month at the gym. You just want to make sure that you catch anything early. Enough so you can intervene if things are heading in the wrong direction. And again, knowing the muscle fat components is really crucial, because again, it's so easy to see weight loss on the scale, but you could be worsening their metabolic health if it's not the right stuff. And for our patients, for metabolic reset throughout the year, they'll do like a reset, what we call our strategic weight loss. They'll do it like twice a year or 2 to 4 times a year, just to kind of reset and keep their body optimal while they're off GLP-1s. So in summary, when a patient is ready to wean off, go off on their own, is really assessing their current state of health, looking at their meds, how can you optimize their supplements, looking at their looking at regular habits. What are they doing that is kind of like a red flag for you? Where can they make some changes? Just like an example would be, and this just popped in my head because it was something that happened. A woman was, it just mentioned that she loves candles, right? And she has them going in her house all the time. Well, that to me right away, it's an opportunity to have the discussion about how toxic candles can be, and could that be contributing to her toxic load, and recommending, alternatives for that, maybe essential oils or something along those lines. Make sure patients understand that they need to make changes in order for changes to stick. You're still going to get people who want to believe that once they have lost the weight, life will be good afterwards and they're going to keep it off. I mean, I think people obviously know that they have to make changes, but reinforcing and making sure they understand that is really important. Always reinforcing the foundations, obviously, which is healthy diet. You got to move. You must sleep at night. And if you're in a constant stress state, that'll keep you on the hamster wheel. And then just having a maintenance plan ready to go for patients, really having an idea of what that overall picture looks like, so that you can easily just modify and create something easy for them to transition to. Okay, so next steps, I guess. Okay, so this is the last session. We are creating a foundations functional weight loss course. We do have a wait list if you're interested in receiving updates on that. And we are going to be offering quarterly office hours. So we will be sending out notifications for that. So anyone that joined our GLP course, which is all of you, we will, have an opportunity for us to get on a call and just answer any questions, talk about any difficult situations, patients, that type of thing. And then just remind you that we do monthly free RD discussions every month. So to watch for that if you're interested in the ongoing education. Other miscellaneous items, don't forget to do your course requirements and provide feedback. We do have a referral credit in Thinkific. If you know any dietitian that's interested in any of our courses, you would get a credit to use for another course. And we are looking for guest speakers for free monthly functional weight loss discussions in certain areas because we're really trying to expand our, the arena that surrounds functional health and weight loss. So that would be if somebody really focuses on hormones in their practice. So we would love to have someone come in and talk about hormones and how it relates to weight loss, the role of genetics and weight, the implications of lifestyle factors such as sleep and stress, really digging deeper into this stuff. The psychology of food and its effect on weight, disordered eating when trying to lose weight. So anything if you're in an area that specializes in, a specific topic and are interested in kind of partnering with us, please reach out to us. And that's it. So I am thankful that I am on time. Does anyone have any questions?
I do have a question.
Yes.
You mentioned about like the here, let me get my camera on. You mentioned about like with the statins having effect on CoQ10 levels and whatnot, and that's something that I'm aware of. But I was wondering if you know like a good place to go to check like drug nutrient interaction type things, because from what I understand, statins can create a CoQ10 depletion, and so that's something that needs to be supplemented in. But when I tried to like research that on my own, as far as like, is it safe with certain statins, I got like I found different information like it may or may not be safe with some of them. So I didn't know if there's like a place you can go to like check that, or what your thoughts on that were.
Yeah, there is. I know that there is. I don't know the drug nutrient interaction. I don't know the sites off the top of my head. I know they're out there.
Okay.
The one that I recommended during this,
Mm-hmm.
that one was specific to looking at the depletions that the medication causes.
Mm-hmm.
So I will look into that and see if I can find a good source, a good
Mm-hmm.
site for that. But yeah, off the top of my head, I can't. I don't remember. If
Okay.
anybody else, maybe somebody else knows, because I definitely know it's out there.
Uh-huh. And then okay, with the monthly RD conversations, will you guys like send out emails ahead of time to let us know when those are,
Oh
or
yeah,
how does that work? Okay.
definitely.
Okay, because I would love to tune into those. And then I just want to mention, I was like looking at the list of things that you talked about to help, like alternatives for medications for helping things with like mood and anxiety and different things. And there's one that I love that I've personally taken myself. I don't know if you've heard of the True Hope brand and Empower Plus, that
I
supplement.
I haven't. No.
Okay. Well, I highly recommend looking into it. It's something that was actually made for helping people with bipolar disorder, but it also helps with like anxiety and OCD. And they have a whole support team in that company. And sometimes they're able to help people like transition from the medications and onto that supplement. It is like a lifetime supplement. It's like you're either going to be on the medication for lifetime or a supplement for lifetime. So which one would you rather do? So I just thought you might want to check into that and see what you think. So,
Yeah, absolutely. And what is it? And I don't have a pen handy. What is it again?
so the company is called True Hope, and
Okay.
the supplement I'm talking about, it's called Empower Plus. So
Okay.
it's
And yeah, okay. So I believe I've seen the Empower Plus. Okay, that's good to know.
okay.
Yeah.
Okay, yeah. All right. Well, I think that's all the questions I had. So,
Okay, awesome.